to know her a little bit better. So I will mute myself.
Perfect. Thanks very much, Jo. So hello, everyone. As Jo said, I'm Alex and I'm currently covering Ruth Lee's maternity leave. So it's nice to kind of show my face without a mask on, and kind of most of you might have spoken to me over the telephone but not actually have any clue what I look like. So as Jo said, there's a Q&A at the end, but as we go, feel free to ask any questions and we can address them at the end. So hopefully this kind of covers a bit of everything. It's not very specific to each patient, but obviously you can get in touch and my contact details will be on later on. So if you need to get in touch later, you can. So let's get started. So just of what I'm covering today: who am I, eating well with a NET, what dietary modifications you might need to do or have come across, your common symptoms that you might experience, how we treat them and what kind of things we can do and modify, and any questions that you might have at the end. So who am I? So my official title, you might all be aware that it's the Robert White Neuroendocrine Oncology Dietitian, and I'm currently covering for the whole year for Ruth's maternity leave. So some of you might know Ruth or have had to talk some by her. So it's just until the end of December, early Jan that I'm covering until she returns. I've previously worked with a NET service up in London, so I had some NET exposure before. So my role is based at Poole UHD and cover Southampton and Portsmouth. Some Portsmouth patients might already know that I'm struggling a little bit to get my login details, but fingers crossed I've got everything set up. So hopefully next week I'll be starting to call the Portsmouth patients as well. At the moment, with the COVID restrictions, we're currently largely telephone video consultations, which is difficult for everyone. Obviously, like I say, you don't know what I look like, which is tricky, but hopefully as things progress, we'll be doing more face-to-face consultations and people, you'll be coming into hospitals again. So hopefully that will be quite nice. So then, first of all, I thought I'd kind of cover what kind of everyone should be doing, kind of eating well and making sure that we're kind of getting enough vitamins and nutrients from what we're eating. So this is for the general population, and actually this can still apply to everyone with a neuroendocrine tumour. We want to make sure you're eating well, getting enough carbohydrates in. So as you can see here, you've got your biggest section is your carbohydrates in your vegetable section, which may be impacted depending on what disease you've got and kind of what advice we need to give you. Then you've got your kind of dairy products, so they can be milks, calcium, rich foods, alternatives. So as long as your soy milks, oat milks, almond milks are replaced with calcium, I don't really mind where they come from. The little skinny section of your oils and spreads. So these are our high fat foods, and obviously they will vary depending on kind of what we want aim-wise from your treatment and management. And then again, you've got your protein sources, so things like your lentils, beans, pulses, fish, chicken, eggs, depending if you're vegetarian or not. And we want to be having those sort of 2 or 3 times a day at least to try and make sure you're getting enough protein in your diet. One thing to think about is actually if you've got any neuroendocrine specific things like carcinoid, which I will cover a bit later on, you might need a little bit more protein in your diet and a bit more split regularly throughout the day. Then on the sort of side of the table, you've got your high sugar, high salt kind of fat foods. So you've got your chocolatey crisps, sauces like ketchup and ice cream and all these good things. And this varies depending on where you are. If we know we're trying to increase your weight, we will probably encourage you to eat more of these foods. But actually, if you're doing very well, you're recovered and your weight is within a healthy range and you've got no symptoms or anything that's related to this, then actually we do want you to limit these every so often. I'm all partial for a bit of cake, but actually we shouldn't be having them daily if your weight's pretty steady and we're kind of just keeping you healthy. And then a little bit about water. So just making sure, you're drinking plenty of fluid in the day. Your teas, coffees, fruit juice, fruit teas all count towards it. So you're aiming for 6 to 8 glasses a day. So then kind of why are we so focused about eating well and why is it specific to neuroendocrine tumours? So we know that keeping a healthy weight, eating well can help you cope with treatment better. We know that it can help recovery after all of your surgery, chemo and radiotherapy that you might undergo now or in the future or in the past. you want to make sure that kind of you're prepared if you do need further treatment, that you're a healthy weight and you're eating well to make sure that this process is as smoothless as it can. It will help support your immune system, help you keep feeling well, hopefully fight off any colds and kind of any bugs and germs that you might get. And it also again help you with a healthy weight and give you more energy. So they're the kind of key focus of why we all want you to be eating well. Obviously, I know that people experience symptoms that might impact you eating so well and impact kind of your oral intake. But this is just kind of keep as a background of actually where you might need to get back to, or where our ultimate goal is if kind of all the rest of your symptoms are well controlled. So things to consider, and I think these are the most specific things kind of from comparing from a normal population to the neuroendocrine tumours, of actually these are the main things that I might start talking to people about and reducing or increasing. So with your fibre intake, so depending if you've had surgery or if you've got an obstruction, we might increase your fibre, we might reduce it down. That almost also will be called something like a low residue diet. And in that, I still want to try and make sure you're getting enough fruits and vegetables in. It's just making those lower fibre choices. So making sure you've got no skins, pips, seeds, all those stringy vegetables, we're keeping those nice and low. You don't really want to be eating those. But things that are like well-cooked, mashable vegetables, so things like parsnips, Swedes, those kinds of things are all okay. And your fruit, things like tinned peaches and pears that are all quite soft, no skins on them, are absolutely fine. So it's important to try and make sure you get enough fruits and vegetables in still, just to get enough vitamins and minerals. Then your fat content, so this will be very patient specific, and I would say that it's worth linking in with me or getting a referral from your nurses and doctors if you are struggling a little bit with fat. It might be that actually you can moderate this in your diet. It might be that we need to increase it, help increase your weight, or actually we might need to adjust medications that we've got you on, and I'll cover that in a little bit more details later on. Your protein again, so making sure you're getting enough of your fish, meat, eggs, beans, pulses, whatever you can enjoy. And again, we want to make sure that if you're taking part in exercise and walking, making sure you're having like a milky drink or some form of protein after, help your muscles repair and regrow. And again, vitamins and minerals. And I think this is a topic and is in part of my questions at the end as kind of what we need to be doing about our vitamins and minerals. So as a sort of broad overview, and these are the kind of common ones I'm looking out for and monitoring. So we know that everyone over our winter months, October to March, should be taking a daily vitamin D tablet. Now, it's just being mindful that we know as the NET population, you are quite high risk of vitamin D deficiency, whether it be from sort of malabsorption sort of symptoms, but most people are low over the winter months, and you might need to take a bit of a higher dose for a period of time, but we will be checking those bloods regularly. If you've got any malabsorption sort of symptoms, it might be beneficial taking a multivitamin that includes calcium, so that it's just being mindful of that as well. If you've had bowel surgery, you may require vitamin B12 injection, but we will do a blood test and then we can review whether or not you need an injection or not. And it should be, we are routinely doing blood sort of yearly when you're coming in to see the doctors and checking all of these things to make sure that they're all within a normal range, and we can adjust and modify kind of the advice that we're giving depending on these results. So your common symptoms that you might experience over your NET journey, you might go from one to the other or only ever experience a couple of these symptoms. But I would say the most common things that I would say I get referrals for were things like weight loss, diarrhea, fat malabsorption, and kind of the causes behind that. There are multiple, and I cover those later. A bit about constipation and some nausea and vomiting. I'd say nausea and vomiting are kind of lower down, but it doesn't mean that you might not experience this as your journey progresses. So your top tips for weight loss and how to overcome this, I want you to try and make sure you're eating small, high energy and protein meals and snacks. So it might be that you feel really overwhelmed by a massive plate of food. Actually, can you split your intake over 4 to 6 smaller meals over the course of the day? I don't really mind. This is when I kind of don't put you on any restrictions. Add all the butter, oil, cream, cheese, yogurts to your soups, stews, fruits and vegetables to try and boost up your calorie intake. If you're struggling, I still want you eating well and eating your fruits and vegetables, but actually I want you to add lots of calories to them so that actually you're gaining some, hopefully starting to gain some weight from this. You can fortify your milk, so adding 3 to 4 tablespoons of skimmed milk powder, which also you might know as Marvel, to a pint of full fat milk, and that just adds up some more calories and protein without making you drink any extra volume, which you might struggle with if you're struggling with a low appetite as well. Lots of nourishing drinks if you can, and if you find that easier to manage. So things like hot chocolate, malted hot drinks, milkshakes, smoothies, as long as your smoothies have got plenty of cream or yogurt or ice cream in. But obviously all of this will be taken into account if you're fat malabsorbing and need to modify these things, and things like your fibre intake as well. So then diarrhoea, and I'd say that you always need a really detailed assessment so that people can assess what's going on and whether or not we need further investigation or changing medications and knowing what's going on. So you will get used to me asking lots of detailed questions. I think you kind of lose the kind of embarrassment or I shouldn't really be telling someone this much about my bowels, but I do always ask lots of questions. I might be asking colours, frequency, so please feel free, answer away. There is no embarrassment here. And as you can see, the Bristol stool chart on the right-hand side, I might ask kind of what it looks like, just so that then we can gauge of where diarrhoea is or what's happening with your bowels, because I've always noticed that one person's normal or one person's diarrhoea might not be the same as the others. So it's always good to clarify and kind of be on the same page when we're talking about it. We know that from a neuroendocrine point of view, you've got lots of different reasons and causes that can lead to diarrhoea. And that's why we ask for so many sort of details and questions about your bowels. We know that it might be pancreatic insufficiency related, surgery might have caused these symptoms, bile acid malabsorption, small intestinal bacterial overgrowth, and I cover those in a little bit more detail later on as well. And you do need support and guidance to help manage these symptoms, because they can really impact your quality of life, and kind of your fear of going out, all of these things. And actually there is lots that we can do and investigate to help try and manage your symptoms and give you a bit more sort of reassurance with your bowel symptoms. And especially I can imagine at the moment, knowing that you're going out, you're not sure what toilets are open or what cafes you can go in to use the toilet. This might be an area that actually quite a lot of people are struggling with, especially over COVID and limiting facilities at the moment. So a little bit about our causes of diarrhoea and kind of what I can do and what you can do to manage this. So pancreatic insufficiency, and this is when your pancreas doesn't produce enough enzymes to help digest and sort of break down and absorb what we're eating. And this may be due to a number of different causes. So medications that we've got you on. So if you're on a monthly injection of your somatostatin analogues, so that's your lanreotide or octreotide injections, they interfere with how your pancreas works. So that's something we need to consider. And you'll always be, when you're put on this, be told to monitor your bowels. If anything changes over that time, then do flag it up to myself or your nurse that you're talking to. Also, a lot of you guys have resection, so you have pancreatic bits of your pancreas removed, and this will impact of how your pancreas works and produces these enzymes. And also, if you've got tumours in the head of your pancreas, that's normally where the area of the pancreas that produces the enzymes. So just being mindful that you might experience sort of these pancreatic insufficiency sort of type symptoms. So what does this kind of look like, and what questions might I ask you? So the symptoms are kind of a red flag. So these for your pancreatic insufficiency, your pale, floating, oily bowel motions, a lot of abdominal pain or bloating, increased flatulence, unexplained weight loss. And that is because you're just malabsorbing. So you're not getting all the goodness that you're eating and drinking. So that's why we look out for these things. So the treatment for this is quite straightforward. It might take a little bit of adjustment for patients, and we do use sort of a drug that's an enzyme replacement. So you might hear us talk about Creon or Nutrizyme 22. And usually people tolerate these quite well. I've got a handful of patients that we might swap from Creon to Nutrizyme, depending on kind of tolerance. But usually it's quite an easy way to manage symptoms. We always adjust it to patients. There's no one set dose kind of fits all, size fits all kind of thing. So it's all a bit of trial and error, and you guys can take control of this and adjust. You don't need someone to say, oh, make sure you're taking this many. Actually, you can adjust it depending on your symptoms. So if you see breakthrough of oily stools or a little bit more wind and bloating, up your creon. Obviously, if that doesn't help, then you bring it back to us and say, look, I've tried this hasn't worked. And just as a reminder, these are all pork enzyme bases. So that actually just to be mindful that they're all, they've got pork in them. So just to let you know, but unfortunately, there's no natural or kind of alternative to using these products. A bit about bile acid malabsorption. So bile is a liquid that facilitates emulsification and digestion of fat. So we know that it's synthesized in the liver, and it's then, most of it is reabsorbed back via the terminal ileum. And you kind of, I would say quite a lot of people experience this as well from a neuroendocrine tumor. And it's usually if you've had some kind of surgery, whether you've had a bit of your disease in your terminal ileum or you've had that removed. Also, if you've had your gallbladder removed, so the cholecystectomy. And this is because that the bile salts reach the colon and cause water to be drawn into the bowel, and they can irritate it. And that's why you see a lot more watery sort of diarrhea. So your symptoms that we kind of experience, and you might have me asking you all these sorts of questions, is your watery diarrhea that's pale, urgency after eating, bowels opening overnight. And there's sometimes, and I see this quite a lot, burning or itching or soreness of the anus, and that's kind of where the bile is coming out and it's making things very sore. So another drug, unfortunately, sorry, I know we give you all these drugs to try and combat these symptoms, but a bile acid sequestrant, they help to bind to the bile acid, and that helps minimize sort of the bile breakthrough and your symptoms. So we start on a lower dose and we increase it as needed, and that's all as well patient specific. I wouldn't say anyone that's always on the set dose, but there's lots of things we can do to help with that. And the drugs that we're talking about here are something called colesevelam or Questrin. Before this started, we were talking about the different drugs, and the colesevelam is a tablet that's quite easy to swallow, whereas the Questrin is more of a powder. And we usually start you on colesevelam, but the powder might be needed if you actually need a small dose, and we can adjust it quite easily, as you can kind of have half a sachet or a quarter of a sachet if needed. Sometimes we do find that low-fat diets can help manage symptoms, especially if you're kind of definitely associating with those symptoms after a high-fat meal. It doesn't obviously mean you can never have fat. It just means that you know that actually the symptoms you might experience if you're having, say, some fish and chips or a pizza or something. So that's just being mindful of it. It can impact our absorption of our fat-soluble vitamins and folic acid. So actually, if we're seeing a lot of bile acid malabsorption and you're still getting a lot of symptoms, we might require vitamin, mineral, calcium and vitamin D replacement. But obviously, if we're absorbing everything well, actually you might not need these replacements as well. But obviously we'll be routinely screening some of these bloods yearly. So kind of we keep an eye on those things and adjust as needed. So your small bacterial overgrowth, so abnormally high numbers of bacteria in the small bowel, and that then causes your kind of symptoms of it. And this can be a result of your slow gut transit, so things moving through quite slowly, and they're things from like octreotide injections. Intestinal obstructions can result in this buildup of bacteria, same with regular antibiotic use, and actually just chronic diarrhea. So actually there's a number again of different side effects and causes of this as well. So our symptoms that we're kind of looking out for are your diarrhea. So as you can see, there's a common factor of always diarrhea, but it's what that diarrhea is like and what are the other associated symptoms with it. So flatulence, abdominal pain, bloating, some vomiting we might see. And again, this can result in things like weight loss and deficiency. So all of these symptoms that we want to be mindful of, and making sure that you're highlighting any of this to your healthcare professionals that you're linking in with, because there are things we can do to help and improve your quality of life. So our treatment, and I would say locally, each sort of centre and each place have their views of whether or not they feel testing is reliable or whether they do it. I think this is still something that's kind of not really been 100% agreed, but actually locally we don't feel that testing is that reliable and that beneficial to patients. And sometimes it can take a long time to get through the process. So initially we might try with a multi-strain probiotic. So we usually recommend something like Bioco or Alpha-X, but you can use your own as long as it's a multi-strain and got lots of different bacteria in there. I'm happy with you using it. They can be a little bit expensive. I think usually it's about £20 or £30 a month. Unfortunately, we can't get these on prescription, which is a bit of a shame. Sometimes we treat it also with a course of antibiotics, and that's probably if your probiotic hasn't really worked or if you're really struggling with these symptoms. But unfortunately, the drug isn't licensed. Rifaximin is usually the antibiotic, but if we need to, we can use it. It may also reoccur and require further treatment. So obviously we want to try and avoid lots of multiple frequency of taking antibiotics if we can help it. And there is some evidence that a FODMAP diet may reduce reoccurrence, but I would say probably in practice, I don't often use that at the moment and don't feel that it's something that we really use, but there is options if you're having regular reoccurrence, there is some things we can do to help. Another thing, so constipation. So again, I would say this isn't very common, but it's good to kind of be aware of it. And you kind of need to know the difference between if you're at risk of obstruction and constipation and kind of what things to look out for. So your constipation should be investigated if it's a new symptom. So do let us know if that is something new and kind of not very normal for you. You want to try and prevent our dehydration. So I'd say probably in the winter months, it's a little bit more tricky to get your kind of fluid intake up. So if we can try and just think about it in interesting ways, so fruit squash or add some lemon or limes to it or mint and things to give you a bit of flavour. A little bit of gentle exercise can help get your bowels moving. Ground linseed, so they're really useful. They absorb lots of water into the stool, making it soft and easier to pass. But obviously, if you're following a low fibre diet, I would kind of limit these if you can, because obviously we don't want to build things up and kind of get a blockage. So this is kind of if you've got no obstructions or no risk of obstructions, then we might advise you to start your linseeds and your high fibre diet. So that's all your whole meal products, your beans, pulses, fruits and vegetables, and that can all help bulk out the stool and get things moving a little bit quicker. And we might, if this is an ongoing thing and we've kind of covered everything else, we might think about some probiotics to see whether that can impact things as well. And obviously there's always laxatives. If we need to, we can always use laxatives and help get things a bit more regular. But these are natural ways and modifications from your diet that can help minimize the risk of constipation as well. So nausea and vomiting, and I would always say that these are kind of symptoms that you might experience if you're going through different treatments, not routinely. So do let your team know if you're kind of suffering with these quite a lot. There are lots of drugs and things that we can help to manage your symptoms and kind of reduce it as much as possible. But sometimes trying to eat little and often, avoid feeling too full. And actually this again might be when you feel quite overwhelmed by a full plate of food. So using smaller plates, smaller cutlery to try and kind of entice yourself in. Try sometimes to avoid the smells of cooking if possible, because sometimes that can be a trigger. And not for colder foods. So like actually don't mind if you're eating sort of cold foods like a sandwich or a quiche or something like that a bit more regularly rather than a cooked meal, that's fine as long as you're getting enough calories in, and these can make it a bit more palatable and enjoyable for you. Sometimes tart flavours, so citrus juices or sorbet or sort of lemony flavour like mousses or yogurts can help, and sort of salty or minty foods can sometimes help with the nausea and vomiting as well. Plain or dry foods, so things like biscuits or crackers or toast can also be a bit more manageable. And I would always say that sort of greasy or fatty foods can sometimes make that nausea and vomiting a little bit worse. But see, this is all kind of just suggestions and things to try. If actually you find you can manage something a bit higher fat, then I don't mind, carry on. It doesn't mean that you need to stop these foods at all. So here are my contact details. So if anyone's spoken to Ruth already, you should have her mobile number saved, and I'm just using that mobile number as well. So you can get in touch with me via mobile, texting or calling. If I don't answer, just leave me a voicemail and I'll get back to you as soon as I can. Do try and leave like a hospital number and your date of birth, just makes it easier to find you on the computer systems. And obviously my email address is alexandra.capon@nhs.net. So you can always get in touch with me that way as well. Also, you can ask your NET nurse or doctor to refer to the dietitian, so they can always re-refer you or contact me and I can get in touch with you. Obviously, if there's a preferred contact time or way of getting in touch with you, do just let me know. I always try to kind of fit it around if people are working or using your mobile number or giving you a set time so that you can be free and easy to have a conversation with me, especially if you're having conversations about your bowels and things. I appreciate you probably want to be in somewhere a bit more private than in out shopping or things like that. So they're kind of the top tips of what I had and what I wanted to cover today. But thank you for sharing some of the questions. So I've kind of just put a few of the questions that people have sent over already kind of on a PowerPoint. So the questions that I've had so far, we'll go through them one by one. Obviously, if you have any more questions, just ask away. As Jo said, I think mine's at the top, so it might be at the bottom. You've got a Q&A button, so you can just type away in there and ask questions, and I should be able to see them if they come through. So the first one, let me just, sorry, something's over my thing. So is there any links with high calcium and NETs, and should I be taking my vitamin D supplement provided by the GP? So recently there was a letter sent out, if you're vulnerable, then you should be taking a vitamin D. And I would say, yes, definitely everyone over the winter months, October to March, should be taking a vitamin D. And we want to be giving you 400 international units or the 10 micrograms over that period of time. There's no direct link with high calcium levels and neuroendocrine tumours. I was chatting about this actually yesterday with a couple of the nurses, and we do think that there might be maybe 1 or 2 people that have had or do have a high calcium, but obviously that's not very common. So I wouldn't be too worried with you continuing taking your vitamin D supplement. And obviously we do check this yearly, and it might depend on the level, depending on when we check your, do your blood. So over the winter months, I'd expect people's level to be lower than if I did it in midsummer and we'd been out having the sun exposure that we sometimes have in the UK. If it is under 30 nanomole per litre, then we do need you to be having a loading dose, and we might prescribe that at the hospital, or we might ask the GP to prescribe this. And that loading dose is 300,000 international units, and it can be given weekly or daily in split doses, so over a period of time, and hopefully that should bring it up. And we should check it after kind of that 6 to 10 weeks of that loading dose to make sure that your levels back up to within normal range. So then I had a few questions about carcinoids. Well, not directly carcinoids, but a bit about serotonin and levels and what we should be avoiding. So I just wanted to give you guys a bit of a background about what carcinoids are. Some people might experience carcinoids and know what they are. Others might not be suffering with them, and kind of you don't need to really worry about this. So we know that neuroendocrine tumours produce hormones which can result in symptoms such as flushing, diarrhoea, wheezing, and damage to your heart valves. And you probably, if you've got carcinoid, then the doctors will have told you this and you'll know. And these symptoms that we have are due to the large amounts of serotonin that the tumours are producing. And basically the picture underneath is kind of showing you how that works. So we know that kind of when there's large amounts of serotonin being produced, that uses a lot of tryptophan. And in that then we result in, because that process is using niacin, we reduce the absorption and the level that we have, and therefore it can cause niacin deficiency. And I would say that probably symptomatic people aren't that symptomatic of this, but actually if you've got carcinoid, you probably will be or are being advised to take vitamin B co-strong. So in that dose, there's kind of split evidence, but routinely we're saying 1 to 2 tablets every day. There is some evidence that you need higher dose, but I think the studies are quite limited and we don't actually know the risk of kind of giving you too high amounts. So actually that's what we stick to, 1 to 2 tablets a day, and then monitor these things. So then linking in with that, and that's kind of think where the questions were about serotonin and when you're having your bloods and urines done and for your 5-HIAA, and when we get advised to reduce your serotonin producing foods. And there's no evidence that the foods produce more serotonin and therefore make the NET worse. And actually we only restrict these so that then next time we know that you haven't had any of these foods, and therefore it can't lead to like a falsely high level. There is no perfect test, and this most definitely isn't. And we use this test and the 5-HIAA in relation with your symptoms and your scan results. But say you were getting a lot of symptoms and your 5-HIAA was high, we would then be like, okay, we need to get you a scan. So it's not directly linked with diet related, and it's just kind of a precursor and kind of looking at and investigating things. Some people do find that serotonin containing foods can cause symptoms, but it's not very common. And I'm not saying that you can't restrict things if you see a direct correlation with symptoms. I'm just saying that I don't really want lots of people restricting foods when we don't think that they're causing any of your symptoms or making things worse, because it can lead to a boring, dull, or kind of overwhelming feeling of, can I eat this? Can I not eat this? I'm feeling a bit exasperated of what is safe or what can I eat? So that's why we don't usually restrict unless you see a direct correlation with your symptoms. Some things that I would say carcinoid trigger foods, and the possible common symptoms and triggers of these are the size of the meal, fat content, spice, and alcohol. And there is some people find that amines can also trigger symptoms. So your high amines are kind of like your aged cheese, alcohol, meat, fish, sort of that are smoked or salted, yeast or fermented tofu, miso or sauerkraut. And then again, your moderate amines, things like your large dose of caffeine, chocolate, peanuts, Brazil nuts, coconuts, sort of these kinds of foods. But I would say maybe in practice, very few people see a direct correlation with these triggers, but it's just to be mindful. If you are having a lot of flushing or symptoms, then it might be worth doing a food and symptom diary just to try and look and assess whether actually you can reduce these. Obviously, if you're having lots of these symptoms, it's likely to be disease related, and actually we might just need to adjust medications and kind of improve control a little bit if we can. So sometimes there might be other causes than just diet triggers that's going on. So a bit about pancreatic insufficiency. Are there any foods to avoid, and how you kind of cover your control your blood sugars? So I think with the pancreatic insufficiency, I've kind of covered what that is and how you manage it. But I wouldn't say there's no foods to avoid really at all with it. You might find that it's just adequate dosing of Creon, that if you're getting breakthrough symptoms of your bowels, then actually it's just you probably need to up your Creon or adjust it. We sometimes split dosing, so take 2 at the start, 2 halfway through, or if meals are taking longer than half an hour, making sure you're kind of spreading it out. Or eventually when we go back
I'm having trouble here.
Oh, sorry, my phone just went. That if you find that you are going out for dinner and you're kind of eating 2 or 3 courses, you might find that you need to treat each meal or each part of the meal as a snack or an extra portion. It's all very patient specific, and if you've got any questions or anything, obviously feel free to get in touch. And also you kind of your blood, so then again about your blood sugar levels, and I would say again it's patient specific. It depends if you're low weight or actually if you're quite steady. We want to make sure you're having some complex carbohydrates at your meal time, so they're the ones with lots of fiber, your brown rice, pasta, skins on your potatoes, and they just slow down the absorption of what you're eating, and therefore your blood sugars have a less peak of that, which is important. Limiting high sugar foods, so jelly, sweets and sugary drinks. But as a whole, I wouldn't say that I want you to be never having cake or biscuits or some high sugar foods. You know, it's all in moderation. And that's when you go back to actually, if you're healthy weights and you're just keeping yourself healthy, actually get back to the Eat Well guide. We can have these foods, but obviously little and often. But if we obviously low in weight, I will want you to be having a few more of these high sugar foods, like your cakes and your biscuits, and I wouldn't be worried about that. We can always review medications and your blood sugars and adjust that as needed. So then someone had just a topic of gastrinomas and kind of any tips about them and how to manage them. So just in case people don't know, a gastrinoma is a pancreatic duodenal neuroendocrine tumour that secretes the hormone gastrin, and this can result in high acid levels, which can cause ulcers and diarrhoea. and other symptoms as well. So depending on your symptoms, you can adjust your diet to see if this helps. So if you're suffering with heartburn or reflux, you can find reducing acidic foods, diarrhea, reducing things like caffeine and alcohol. But again, it might be medication. You might just need a PPI, so something like a omeprazole or lansoprazole that actually just reduces the acid in your stomach. So I wouldn't say there's anything specifically, but actually you might find that kind of there are some modifications, also things like sitting upright after meals for half an hour and avoiding sort of laying down flat. You might find propping up a pillow can help with some of these symptoms as well. Just a general topic of overnight fasting. Do we think they're safe? Should we be doing it? So it's not really recommended. We don't really say that fasting is very safe, because it can lead to weight loss and also restrictions, and kind of it can really impact your symptoms of that as well. I mean, typically we tend to fast overnight anyway when we're asleep, but it's not essentially required. And I don't mind saying you're struggling with your weight and you're waking up in the middle of the night and you're feeling a bit peckish, by all means help yourself to something to eat. That's no problem at all. It also, with the fasting periods and timings of that, it's less time to eat, so less food that you can get in over that period of time. And also that might then impact things like vitamins and minerals that you're getting in from your diet as well. So they're things of a broader topic to think about, that actually fasting isn't kind of yes or no. Actually, there are things it results in that I wouldn't be wanting you to do. So then this is kind of like a broad one, and I think I've kind of covered bits of it. So deficiencies and supplements, should we be taking them? Shouldn't we? Am I at risk? Is it a waste of money? So your vitamin and mineral supplements, you are at risk as a net population, depending on your surgery, your treatments. So we know if you're fat malabsorbing, you're higher risk than, say, a normal individual. If you're struggling with eating and drinking, your volumes might be different of eating and therefore not be able to get all your vitamins and minerals. And if you've had your terminal ileum removed, you are at risk of vitamin B12 deficiency. So we will be monitoring all of these as well. Obviously, if you're feeling tiredness or you're noticing symptoms that you might associate with vitamin and mineral deficiency, so things like hair loss, fatigue, things like that, do flag it to your team, and it might be that we just do a kind of set of bloods on things. But I would say that it probably isn't any harm of taking a multivitamin, just making sure that you're kind of not doubling up on lots of different tablets. And there are lots of different natural tablets that some people ask, and I would always say it's worth checking those things with the doctor. We don't routinely suggest that you should be taking anything else or these herbal remedies, because we don't actually know how they interfere with medications or chemo or radiotherapy. So do flag it if you're taking anything else to your team. And then there was a question about kind of timing of taking a multivitamin and kind of when's best to take them. And obviously people who are taking colesevelam or a bile acid question, so like question, might be aware that there should be like a 4-hour window between taking that drug and another drug. And that's because it can inhibit and stop absorption. So I'd always say avoiding a multivitamin 4 hours window of your colesevelam or your question, and avoiding sometimes around the time things like caffeine, because that can impact absorption of different vitamins and minerals as well. So some people might find that kind of before bed might be an optimum kind of window, or at lunchtime. So just do when it kind of suits you. There's no right or wrong, but it's just being mindful of other ways and other things that can impact the absorption. So that's kind of the end of my topic and kind of my presentation. I don't think any questions have come through as of yet, but if does anyone have any questions or anything they wanted to ask?
I've got a question. Yeah. So you actually answered one of the questions I'd asked. So I take colesevelam. I take that 2 tablets 3 times a day. So I'm already sort of managing the pills through the day. So how would I manage to kind of have 4-hour gaps to take my multivitamin? Because first of all, it's remembering you've got all these like intervals through the day, but also there's not an awful lot of time in between to make sure that I'm absorbing the vitamins. And would that mean that it's pointless taking the vitamin, or is it just not quite as
Yeah,
good?
so I guess that is some of the hardest things that patients often find, is actually trying to make sure they're kind of remembering all the drugs at set times and how to manage that in a day, and especially if you're busy or you're here, there and everywhere. So I'd always say, if you can, normally what we say about taking colesevelam is always like taking it at lunchtime and dinner time, because they're the times when you're probably less likely to be taking other drugs. And it just means that it probably might not be absorbed as well as it would be if you took it within that window of the 4 hours. I mean, if you can leave it as long as possible, and it might be an hour or 2 hours, obviously that's better. But that's why I say kind of maybe in the evening before bed, because you can kind of leave them on your bedside or leave them in the bathroom, and hopefully that's then a trigger, be like, oh, okay, I know I need to remember taking those. But it's not easy, and I think it sometimes is quite hard to kind of move drugs around and make sure you're taking everything at the right time when you're taking lots of different drugs.
Yeah, because I take my colesevelam before bedtime as well, so I do the pill box. It goes from one place to the other so that I remember to take them. So it's just kind of managing everything, isn't it? But it's good to know that it's not a complete waste of time if there's not that 4-hour gap.
Okay. Got a couple of.
You have got a question now. So first of all, yes, I think you will have access to the slides. That's okay, isn't it? And also I've recorded this meeting. So assuming that the meeting has recorded okay, I will then share that, and I will put that into the Facebook group, and I'll put it onto our YouTube channel. So you will be able to watch this again, because there's a lot of information. Actually, loads of information. It's been really interesting. I think you've got another question now as well.
Got a couple. So I've got one that says, my stools always float. What does that mean, regardless of colour? So that is likely to mean that there is some fat in there, that's why it's floating. So I guess it's just thinking about kind of what kind of treatment you're on and what kind of other symptoms you might have, and it's how to manage that. So I'd probably want a few more questions to ask you and kind of work out what is going on, and whether you're on Creon or colesevelam, and actually whether they need to be adjusted. So hopefully that helps, but it might be that you kind of get in touch, and then I can do a bit of a better assessment and help, like as a patient specific question from that. And then another one, if you take colesevelam, then consider Creon. Do you have to give up colesevelam? So if you've got symptoms, and I guess that's where it's being mindful and why we always ask such a detailed bowel history kind of detailed assessment, because it's working out what actually is going on from a symptom. Is it bile acid? Is it pancreatic insufficiency? And I think that's what you're saying. But actually, if you're taking colesevelam, you can be taking Creon at the same time. You can have pancreatic insufficiency and BAM, so the bile acid malabsorption. So no, you don't have to be giving up colesevelam if you start Creon, but it's just looking through of why are you having breakthrough symptoms and what are the symptoms like, so that then you can kind of get a clearer picture. Again, it might be that actually you talk to me directly, that then we can answer that a bit more patient specific for you.
Has anyone else got any questions for Alex? I found this really interesting. I think it's actually in some ways easier to concentrate in this sort of online scenario than it is in the conferences. So I feel like I've taken in a lot more today than sometimes I do. So I hope everyone else has found it just as interesting. Lots of great questions, some things that I wouldn't have thought to ask. So sort of learning things that you didn't realise you didn't know, which is brilliant.
Can I ask a quick question before we go?
Of course.
I've just thought of one, and I've always had low blood pressure, and I've always issued with waking up in the morning and feeling of passing out. I try to drink water. I dislike water, so it's quite difficult. Are there any foods that I can eat or anything else I can do from a nutrition point of view to keep my blood pressure on an even keel?
So no, I mean, salt can sometimes help. Obviously, I probably wouldn't want you downing loads of salt, but actually have more like salty food, try and see whether that can help.
Yeah.
Like other things like teas or coffees or like fruit juice or squash, even if that's easier to try and keep your fluid intake up, might help. But there's no real, it might also be medication related that your blood pressure's low as well. So
Yeah.
it is, try a bit of extra salt, see whether that has an impact on it, because that can help keep your blood, like normally obviously we tell people not to have much salt if you to help your blood pressure low, but yeah, just give it a go and see whether it makes a difference.
Okay, thank you.
Could Layla be feeling dizzy because of lack of food? Is it sometimes that if you're not eating regularly? I find if I'm really hungry, I can feel a bit dizzy.
Yeah, and I guess that's it. There are other causes of the dizziness. And I guess, Layla, do you have your blood pressure checked? Are you always a bit on the low side, or?
Yeah, it's always been low. Yeah. I just, I get to, if I don't drink a lot, I can be almost, I think my carcinoid syndrome has got worse and worse, obviously, over the last 12 years. And it's, I could deal with it before, but I'm getting very close to almost passing out. Every time I had an operation, I'd always be very, very low blood pressure. But I think as time goes by, it's getting more and more. I had to sit down in Tesco's the other day, which is a bit embarrassing, and have a glass of water brought to me, and I know the feeling, I know how to manage it and how to deal with it. But I just thought, there's got to be more I can do. I have upped my water. And I need to do that anyway, but I just wondered, really. I mean, the only other thing I'm on is teletriostat. I'm on and I take a bit of loperamide or cholesevelam occasionally, but the teletriostat, I didn't know whether it might have been that, but I'm going to be taking something if I'm not taking that.
Yeah,
I've kind of done all sorts. I've had Questran, I've had, the cholesevelam, I've had teletriostat, loperamide, pretty much tried all of it, Creon as well. And I think sometimes it's giving your body something new, to test is good. But I think with the blood pressure, for me, that's always a bit of an issue.
and I guess if you are dehydrated, having, like, if your bowels are open quite a lot and you pass a lot of stool, that's not going to be helping. I mean, have you tried Diarrhoea or anything like that?
Yes, but again, it's like Joe said, I've got all these tablets to take, and I've got all these supplements. I try and take curcumin and magnesium and some other stuff, and I tried niacin at one point, and that was just horrific, far too itchy. But it's trying to remember, and I think, okay, I'll put them where the tea bags are, and it's. I think for me, it's. I don't want a great. I've seen online you can buy those great big pill things. I just think I don't really want to get to that stage, but it's just trying to juggle. And it's like vitamin D. I don't take vitamin D, and I know I should. And I just think, it's another one, and
another tablet.
Because you're taking so many. You're then, especially with people that take Creon. I know we don't, in our sort of world, we don't take a lot of Creon compared to some others that are on an awful lot of Creon. But you do wonder, the contra effect they're having on each tablet that you take, and at what point. And I'm quite a busy person. Well, I'm a very busy person, so it's I almost think I need an alarm and a robot.
Yeah. You just hand out the drugs every time you need them.
Yeah, so I think I suppose it's like anything, it's juggling and getting it right, isn't it?
And I would say see whether taking Diarrhoea every morning makes a difference, because I think it probably might be that the dehydration, actually, if you're keeping, and that will just help the absorption and keep hold of that.
Yeah, so in the morning rather than the evening.
Yeah. And see whether that helps. I'm guessing they've done bloods and checked your sodium and stuff. And,
I'm on a trial at the moment, so I'm constantly monitored. So
constantly giving out blood.
Yes. Yes.
And I think someone's just asking another question. I eat lots of mixed seeds. Is this bad for malabsorption? So no, it's not bad for malabsorption. Some of them are a bit higher in fat, so you might find your symptoms are worse. But actually, no, good amount of vitamins and minerals in your seeds and nuts and things. So absolutely fine, as long as you're not in obstruction or at risk of obstruction. Fine with lots of fibre in that as well. So that's okay.
So I'm not sure if anyone's got any more questions, but there's been lots of great questions so far. So I think hopefully everyone will take something away from this and have found it useful. Obviously, Alex has already said everything is very patient specific. So if you want to speak to Alex direct, she's given you the number, and I will share this again with the number on. So you will have that, and you can watch it again and maybe sort of absorb a little bit more of what we've spoken about. If you think of any questions afterwards which have sprung up because of what we've been talking about, you can email Alex or get in touch with us, and we'll pass that on to Alex as well. But I think we can all agree it's been really useful. So we'll maybe do this again sometime. Thanks, Alex.
No, thank you for having me. It's been great. Been great to be kind of on today and kind of show everyone who I am. And it's nice to kind of feel welcomed into something that I'm kind of looking after for Ruth. So it's nice to be part of the team.
Thank you. So thanks everyone for joining us. I will log us out in just a second, but like I said, if you think of anything afterwards, then Alex is available to talk to. That's what she's here for, and it's I think as NET patients we're really lucky to have this service. So thank you. Okay, and everyone enjoy the rest of your day. See you later, everyone.
Bye, everybody.
Bye, everyone.
Bye.